Hi, my name is Mark Jones, and it's an honor to be presenting at this prestigious conference organized by Dean Watson. The title of my presentation is Diagnosis is Easy, Clinical Reasoning is Hard. And I plan to use a case study from our new text, Clinical Reasoning in Musculoskeletal Practice. This is a case by Gwendolyn Joel, Michelle Sterling, Darren Rivette, and myself. I'm going to use the case in order to highlight key concepts in clinical reasoning of this patient who happens to have neck pain and headache. But in particular, I'm going to highlight the scope of clinical reasoning judgments and management that's focused on impairment necessary for skilled clinical reasoning. I'll also highlight the scope of psychosocial focused reasoning, which is often less developed in musculoskeletal physiotherapists as compared to their diagnostic physical focused clinical reasoning. And on the basis of that, I'm going to propose a framework for a more thorough, structured psychosocial assessment for all of our patients. I then will highlight the scope of multimodal management that was evident in this particular case, addressing the patient's understanding, expectations, specific impairments, and functions. And as I work through the whole presentation, I'll be highlighting for you specific strategies to minimize clinical reasoning errors. The first 6 or 7 slides are the patient's subjective examination presented. In this first slide, it covers the patient's main problem, her work, family, and social circumstances. But as you listen to this presentation, I'd like you to be considering the diagnosis that you would attribute to the presentation, and what's the scope of clinical reasoning judgments that you would entertain. All right, Emma was a 38-year-old who was referred for neck pain 10 days post motor vehicle crash. She works full-time as a partner in a law practice. She's married with 2 children, 11 and 9 years. She walks with her friends for exercise approximately 3 times a week. Our weekends tend to be busy with her children, her household activities, and social events. She doesn't have any experience personally or professionally with whiplash injuries, but she had heard they could be problematic for some people. She had not lodged a claim for third-party insurance, but she's intending to do so in order to cover the costs for her car and treatment. This is Emma's body chart, which will look very familiar to everyone. It's a very common presentation of neck pain and headache. So she had primarily right-sided neck pain that would then develop into a headache when the neck was worse. And both the headache and the neck pain were 6 out of 10 on average on a visual analog scale. She also reported having slight dizziness, lightheadedness, and an unsteady feeling when the headache was worse. When screened, she didn't report any migraine, VBI, cervical arterial dissection, or cord-associated symptoms except for that dizziness, lightheadedness. Her behavior symptoms, or the activity and participation presentation, were such that her neck pain was constant but variable. It was typically worse when she was at work on her computer, and especially for longer periods of time, say 30 to 60 minutes, without moving around. And she would get a sharp pain if she turned her head too quickly. This was of a higher intensity, 8 out of 10. It would settle in a few minutes, but once she had an overall increase in pain, it was then difficult to get relief. The headaches only developed in the afternoon as the neck pain increased. The lightheadedness was intermittent, and again, only when the headache was worse. They only lasted a few seconds or minutes, but they were bothersome for her. She did get pain relief from tramadol medication, which is an opioid, and also lying down with a hot pack for, say, 30 minutes when she was home. She thought the tramadol was helping, and she didn't associate the lightheadedness with the tramadol. She is able to work. She's continuing her work, but under reduced hours, and she's a little bit anxious about her productivity. She's getting support from the paralegal at her firm, but she knows that she can't expect that indefinitely. At home, she's still participating, for example, in cooking, but the husband and children are helping out with things such as cleaning, washing, and shopping. Her sleep is disturbed, but it's improving. She tends to sleep on one side with 2 soft pillows. She also acknowledged having dreams about the accident, and she's waking occasionally with the sound of screeching brakes. She's currently without her car, so she's taken a taxi to work, and she's been asking the taxi driver to avoid the intersection of the crash. An overview of her behavior were such that her Neck Disability Index score was 22 out of 50, and the Patient-Specific Functional Scale ranks nominated activities from 0 to 10, and 0 meaning you can't do them at all, 10 meaning they're normal. Turning the head, she rated 1. Computer work for 60 minutes was a 3. Cooking, particularly lifting pots, was a 5. And walking with friends, she had stopped altogether, so that was 0. General health was good. There was no medical or surgical history. And then the history of the actual incident, it occurred 10 days prior on her way to work. She was stationary at red lights. She heard a screeching of brakes the instant before she was hit from the rear. She felt a jolt, an immediate sudden twinge of pain in her neck. The car was hit directly in the rear, and the bumper bar and the boot were crushed. The police did attend the accident. The car was towed away to a repair shop, and the police advised her to have her neck checked just as a precaution. She didn't think her neck was too bad immediately at the time, so she caught a taxi to work. But during the day, the neck pain gradually increased, and then it progressed by the end of the day to include the headache. So she went home. She took 2 Nurofen, which is an over-the-counter anti-inflammatory, and went to bed early. She had a poor night. She was restless with the neck pain, and she woke the next morning with the neck feeling stiff and sore. She went to her general practitioner the next day, and he had advised to take the day off of work and also organized for x-rays, which were normal. He diagnosed her as having a soft tissue injury in the neck and prescribed initially Panadol Osteo, which is a paracetamol, and to continue work, but to take it easy for the next few days. She returned to the GP a week later because the neck pain was getting worse. At that time, he changed the medication and prescribed the Tramadol, which is an opioid pain medication, and he referred her on to physiotherapy. She didn't have any previous history of neck pain or headache. Okay, so that's a snapshot overview of the presentation. I think it would be very familiar to most physiotherapists. And getting to the title of my presentation, Diagnosis is Easy, Reasoning is Hard, it really depends on what system or categorization you use to diagnose your patients. And there are, obviously, you'd know, many different ways of categorizing patient presentation. What I've done is borrowed the categorization of neck pain disorders from the recent text by Guangzhou et al. On management of neck pain disorders, which is an excellent textbook. And they gave this example of 4 categories on which to diagnose neck pain. Idiopathic, which could be either mechanical postural in origin or degenerative. Trauma-induced, for example, whiplash associated. Cervical radiculopathy or cervical myelopathy. And then a broader category of non-musculoskeletal associated neck pain. And this could be a whole range of things from infections, neoplasms, neurological, visceral disease. But as you can see, putting the patient into one of those, with the patient's presentation into one of those categories isn't particularly difficult. So Emma clearly falls into the trauma-induced, whiplash-associated neck pain. Hence, it's easy in that sense to categorize the diagnosis. And diagnostic categorization is important, just as pathology reasoning, focused reasoning, considering potential pathologies, especially ruling out sinister pathologies and red flags is really important. We have clinical guidelines for neck pain, for radiculopathy, for whiplash, and I've listed a range of them here, which are really useful guides for clinicians in terms of what should be incorporated in assessment and management on an evidence-based perspective. So those guidelines are useful, and they are based around diagnostic categorizations. Similarly, as I've said, red flag screening for potential serious or non-musculoskeletal pathology is essential. And in this case, we've had screening via X-ray to rule out fracture. So even though pathology is really essential to consider, and the potential for specific pathologies, such as spondylosis or radiculopathy or fracture, we do need to be careful not to over-focus on pathology. And the reasons include that some pathologies will be present on imaging, but be asymptomatic. So many patients with, for example, spondylosis can have an asymptomatic presentation. Symptoms can exist without detectable pathology. So there isn't anything available or evident on the imaging screen, but the patients have sufficient strain on the tissues leading to nociception and eventually pain. Symptomatic pathology can be present, but present quite differently in different patients. So if you're only focusing on the pathology, that's insufficient to guide your management. Pathology is not a very good or efficient outcome measure to guide progression of treatment. And as you know, some patients will over-focus on their pathology, and that can then precipitate fear of damage and lead to other complications. So what I wanted to bring out then is, even though diagnosis and diagnostic categorizations are important to direct us to relevant clinical guidelines, that they're inadequate on their own to guide management for the individual patient in front of us. And therefore, we need to think further about how we can categorize the patient's presentation. And what I'm suggesting is, in addition to the more formal diagnostic classification, we have these other forms of classifications. The first one here being your hypothesized symptom mechanism or pain type, nociceptive, neuropathic, nociplastic. Your recognition of the pattern of activity and participation restrictions. So specifically the movement pattern, the postural pattern, the load patterns for your individual patient. The activity and participation related physical impairments, and the pattern of those impairments is important to incorporate into your own categorization. And similarly, the activity and participation related psychosocial impairments that may be present need to be identified and categorized. And then lastly, it's useful to also hypothesize about possible sources of the symptoms and contributing factors, factors that contribute to the onset or the maintenance of the problem. And I'll talk through each of these a bit more as I progress. Now, once the red flags and specific pathologies have been ruled out, our management then can focus on education, function, physical impairments, psychosocial impairments if they're present, and environmental factors. Okay, and that's what I've tried to do with this hypothesis category framework. It's essentially a framework that represents the range of clinical judgments that clinicians need to, and I would argue should be making in clinical practice. It's biopsychosocial, so it's not just focused on a biomedical diagnosis or pathology, but it incorporates that. And we'll talk through these in the context of Emma's case. Okay, so if we start at the beginning in our analysis of the patient's activity and participation behavior, well, we already know from the patient-specific functional scale that she's got these levels of difficulty with the nominated activities. What I want to highlight here is these are things that Emma volunteered. But in addition to what she nominates as troublesome activities or restricted activities, we need to also consider screening for other things. And this is an important strategy to minimize errors. So looking for what else might be present beside these, and then in particular, with different activities, trying to understand the patterns that exist within the aggravating factors? What's the dominant theme to the aggravating factors, for example? So screening with all patients whether there are any problems with movement. Now that would be, of course, movements of the neck, but also movements of the arms, because we know the cervical spine is going to be loaded, moved and loaded with arm movement. And we would similarly screen for movements of the spine, screen for postures of the neck, the spine, even the lower limbs, because of the potential, for example, of neuromeningeal stress, transmitting stress up through the spine. And then, of course, load, literally adding additional load, such as lifting, carrying, pushing, pulling. So screening explicitly, not just waiting to see if they're offered or volunteered, and then when we find an aggravating factor in any of the movement, posture, load themes, we then clarify so we fully understand what is it about that factor. So what is it about the computer work, the cooking, the walking with the friends? So we understand, rather than making a reasoning error and assuming it's what we thought it might be. So we don't assume, we clarify. Okay, the next category in the hypothesis framework is to think about patients' perspectives, which is synonymous with their psychosocial status. And unlike categorization of a broad diagnosis, this is challenging. This is hard, a hard part of our reasoning. And this is an area I'd like to elaborate a little bit more on in my presentation, because we know from our own research that it's an area that many musculoskeletal physiotherapists feel under-equipped. They haven't had adequate training, they tell us, and they're not confident in their psychosocial assessment, reasoning, or management. So let's consider, what do we really mean when we say psychosocial? What are the psychological aspects? What are the social aspects? What effects can they have? So what are we looking for? What specifically should we assess? And I'm going to argue that we need to have a semi-structured psychosocial assessment in a similar way that we have a structured physical assessment with our patients. When we find factors in that psychosocial domain, how do we know whether a factor is relevant or not? Because many people without any problems, without any musculoskeletal pain or injury, will have psychosocial factors present in their life. So they could be coexisting, or they could be contributing to the patient's symptoms and disability. So how do we make those judgments? And of course, how do we manage this? Okay, so let's look specifically at Emma's case and what we know from what was presented in her case. So under the subcategory psychological, these are the things we've learned. We've learned that she has some awareness of motor vehicle crashes being problematic. We don't really know enough about what that means to her and whether that's concerning to her or not. We know that she has some anxiety about her productivity, and she's not going to get continued assistance indefinitely. She told us that she's having dreams about the accident, and she's actually waking to the screeching of brakes, so that fits into that psychological experience. And we know something about her coping strategies, in other words, what she's doing to cope with her presentation. So she's using rest and heat, she's using medication, she's asked the taxi driver to avoid the site of the crash, she's reducing her hours at work, and she's reducing some of her home activities. So we know that. Under the social domain, we know that her husband and children appear to be helping out at home with the cleaning, the washing, and the shopping. The employer appears to be supportive in that it's allowing a degree of reduced hours. And we don't really know with the friends because she's not walking with them, but we don't know what other engagement she has. So this is a good time to stop and just reflect a little bit about some common errors of reasoning. There are many different types of clinical reasoning errors, and I'm just going to focus on three here. One has been called priming, and that's the influence of prior information. Now, we always have to interpret information, but unfortunately, sometimes we're biased by prior information. It takes the focus of our attention. And two classic examples of priming are when you're provided with a diagnosis in the referral, and the therapist doesn't look beyond that diagnosis, so they just consider that without considering alternative explanations. And it's the same with imaging findings. If you get a patient with brings in imaging findings that show pathology, that pathology can bias the person to believing that's the source of the symptoms. That pathology and those structures are where the nociception and the symptoms are emanating from, which of course can be true, but we also know, as I said in my earlier slide, that pathology can be present and asymptomatic. So that is a bias we need to be cautious of avoiding. Now, associated with this is probably the most common error, and that's confirmation bias. And that is, once you've got an impression of a patient's problem, so whether it's from the diagnosis or the imaging findings, that then takes the focus of your attention, and you don't look for alternative explanations. So all of the information that you gain from that initial impression tends to just look at that. It doesn't consider alternative hypotheses. You're just trying to confirm your first impression. And the last one, and I've got this one in red because it's one that I see a lot in postgraduate physiotherapy, where students make an assumption that what the patient volunteers is all that's present, that's all that's necessary, that's all I need to find out. In fact, this error of reasoning has been called "what you see is all there is." And that's a phrase that comes from Daniel Kahneman, who has an excellent book on fast and slow thinking. It's about human judgment and errors in human judgment. And this error is the assumption or the acceptance that the information at hand is all that's available. And this happens a lot. And there are strategies to minimize this. Okay, staying into this topic of psychosocial, we do know from research that physiotherapy, psychologically informed interventions, can significantly improve patients' pain, disability, and psychological outcomes. So we've got a growing body of evidence that physiotherapists can successfully manage these problems in our patients. However, qualitative research, and some of our own research has specifically looked at this, shows that many musculoskeletal physiotherapists actually don't feel confident in this domain. And if you explore that further with them, it goes back to their insufficient training, or they had a certain amount of theoretical training, but they didn't have clinical practice in using that training. So what you often find is musculoskeletal physiotherapists don't have a structured psychosocial assessment. They can't tell you, here are the categories of questions I ask, here are the questionnaires I use. They don't have criteria for judging whether a factor is relevant or not, and they're not confident in their management strategies. So it is a problem that needs to be addressed. If we look at the theory underpinning psychosocial factors and their contribution to health and disability, it often takes us back to the stress and coping theory, which comes from Lazarus and Cohen. And essentially what they argued and demonstrated was that pain and disability are themselves a source of stress. And how the person responds to that depends on a combination of their interpretation or appraisal of that, so what it means to them, and specific strategies they use to cope with the stress. Now, those coping strategies will have outcomes as to how effective they are for the person, and those outcomes will then influence their reappraisal of their pain and their disability and can contribute to it. But the key points on this slide are cognitive appraisal, and this essentially is the patient's conscious and precognitive judgments, the meaning that the pain, the diagnosis, the disability has to the individual. And meaning is the key word there. Is it something benign that I'm not overly concerned about, or is it threatening to me? And we'll come back to explore threatening a bit. Also included in their cognitive appraisal is their belief, their judgment about whether the problem will resolve. Where they're coping is the explicit things they do. What have they done to help cope with, master, tolerate their pain or their disability? And where I'm going with this is these are the things that need to explicitly be built into our patient assessments. Okay, threat. So this isn't new. We've been hearing this for a number of years, how important threat is, and it's the threat the person perceives that actually determines whether nociception is experienced as pain or not. And there's research, in fact it's been around for a long time, that looked at what are the variables that people use to judge whether something's threatening or not. And these are important to understand because as I said, they will influence what we assess, what we screen in this psychosocial domain. And when you look at these, they really are common sense. So it's the person's beliefs about how serious their problem is. Is it something that is going to resolve on its own or not? Or is it an indication of a more serious, sinister pathology? It's their belief or their judgment about the extent their life is affected. It's their perception of the social impact the problem, the pain, the disability has on them, which can manifest as a social stigma, the shame the person might feel, the guilt they feel in terms of their contribution as a parent or a spouse or a co-worker. And then lastly, it's their perception of the controllability and changeability. Can this thing be helped? And in fact, if you look at whiplash-associated disorders in particular, this is also highlighted there as expectation of recovery being an independent prognostic factor. Bottom line is, this is something that needs to be incorporated into our assessment and into our psychosocial focused reasoning. Okay, so let's summarize that. What I'm saying here is that we need to explicitly assess, have a structured approach to our psychosocial assessment. And I've just nominated 3 broad categories: the cognitive appraisal of the person, the distress or negative emotions that they are experiencing, and their coping strategies. What we're exploring under each of these, so it's not just asking about their cognitive appraisal, what we mean by that is asking them about their understanding. And not just what the doctor told them is going on, but what it actually means to them. What does it mean to them in terms of their expectations for recovery, whether they feel they can contribute in the management or not, and whether they can achieve some of the goals and get back to where they used to be. So we're exploring things like understanding, beliefs, self-concept, self-efficacy. Do they feel they can contribute to the management, their acceptance of what's occurred, their expectations for recovery, and their goals. And then as we go through those, we listen for, and sometimes we have to explicitly ask about their threat appraisal in terms of their judgment about how serious do you feel this is? What kind of impact has it had on your life? Now that may come out spontaneously in the behavior of symptoms, but we may also explicitly ask that question. What social effects is it having? How is it affecting your social life, your relationships at work, at home, with your friends? And importantly, their perception of changeability. And then with all of that, we should also be trying to judge their motivation for change, particularly for those patients who have been referred for physiotherapy. It's not necessarily their choice. And is it something that they want to work toward and participate in? The second category is the distress, and particularly here, the negative emotions, the anxiety, the anger, the frustration, the fear, the self-worth that they feel, and even depression. Not just whether it's present, and this is what unfortunately happens too often. A superficial assessment is, yes, my patient has anxiety, but what's the relationship of any of those emotions to the patient's symptoms? And what's the consequence? What is the effect it has on their behaviors? Because they're the things that help us determine whether it's relevant and contributing to the patient's presentation or not. And the third category is coping strategies. And this should be an explicit section of our subjective screening of our patients. So do you have any specific coping strategies? What sort of things have you tried to help you cope with this? And there are going to be things like the patient's avoidance, but other patients will exercise to cope. Other patients will take medications or rest or use relaxation strategies or distraction strategies. So there's a lot of things to be familiar with. So what do they do and how successful are they? And they can not only be behaviors, they can be thoughts. So patients will engage in catastrophizing as a way of responding and coping with their problem, or hypervigilance over attending to body symptoms. And other people use acceptance as an acceptance of what's occurred as a form of coping strategy. Now these themes here that I'm suggesting get screened in our subjective, the patient's thoughts, emotions, and their coping strategies. It's important we recognize these are not just dichotomous, absolute variables. You either have it or you don't. They're continuous. They occur on a continuum. And that'll be important because they can be, as I'll show you in a moment, more minor or more serious, and that influences what we can and can't do. But what I want to highlight in this slide is the range of influences they can have on our patients. So they can influence their sensitivity to mechanical and non-mechanical stimuli, their pain intensity, their pain tolerance, their function, their behaviors such as avoidance or overactivity, their care seeking such as passive coping strategies, their self-concept, their self-worth, their self-efficacy in terms of what they feel they can do and participate with, their relationships at home and at work, their quality of life, and their expectations for recovery, for participation, whether they expect to be involved in, for example, home exercise. So this slide really highlights the overwhelming importance that we address these things, and this slide emphasizes that they occur on a continuum. So let's look at the lower end of the continuum. You can have a patient with selective attention to sensory information, low levels of movement, fear avoidance, and frustration with activity and participation restrictions. They're frustrated because they can't play their sport or they can't walk with their friends. And to recognize that that can be just a very normal response to pain or to disability. That in itself isn't maladaptive. Many of those patients will simply adjust over time. So as their problem improves, naturally and with physiotherapy, those frustrations, even the low-level fears, will dissipate. Or they might respond, or they might require some education to help them understand what they're going through, what's happening, and the course of recovery that will likely occur, and where physiotherapy can assist, and sometimes some degree of behavioral interventions and graded activity, which is really in many ways another way of saying progressive loading. So pulling people back from things when it's appropriate, and then gradually guiding them when they can do more. Now, if we go all the way to the other end of the continuum, you get these extreme situations where there's greater pain and disability-associated stress. That means greater distress, and then you can start to see the emergence of catastrophizing cognitions, hypervigilance, overattending to all their body sensations, and a broader fear avoidance. Not just fear of movement, but fear of socializing, fear of even being near other people. With the higher distress, negative thoughts, and emotions, they can be enmeshed or intermixed with their negative self-concept and self-worth. So they don't feel they're a good parent or spouse or worker. And that can start to lead to more extreme psychological constructs such as helplessness, hopelessness, guilt, despair, and depression. And that theory of enmeshment comes from the work of Pincus and Morley. And clearly, people at that end of the continuum, they are going to require more than probably a physiotherapist. So they're going to need a referral to a psychologist or some form of counselor. But the key here is that it's going to be a co-management. It's going to be us working with them to be able to to help this patient, because we will have a lot to offer in the pain education and the graded activity and graded exercise return. Okay, but psychological factors can also be positive, and I find it often the case where my postgraduate students think of psychosocial only as a negative construct, that you have negative thoughts and negative feelings. Here's a quote from a really excellent paper by Edwards et al., highlighting the importance of these variables. So he says here, psychological variables such as depression, anxiety, and distress are among the most potent and robust predictors of the transition from acute to chronic pain. But of course, not everybody progresses. Majority of our patients don't progress. So it's interesting to consider what are the factors that predispose somebody to progressing. And so there can be negative emotions, as I've talked about before, that we should be screening for and understanding, including their relationship to the symptoms and the patient's behaviors. And they can create a risk factor vulnerability for developing chronic persistent pain and disability. They can also be a consequence of chronic pain and disability, so they may come after the fact. The last point there is that social support from home, from friends, from work, acceptance of what's occurred to you, and good self-efficacy, that you want to participate, you want to be able to help manage your own problem, they can counter the negative factors, and in turn they are then fostering resilience. So we need to think about these as positives, and this is really nicely demonstrated in this figure from the Edwards paper, with on the left-hand side showing the examples of risk and vulnerability, the distress, the trauma, the fear, the catastrophizing as examples. And on the right-hand side, examples of resilience and protective factors, the social support, the active coping, the acceptance, the self-efficacy, so that when we're screening for our patients psychosocial factors, and in particular the psychological and the social support factors, we need to be listening for both the positives and negatives in terms of judging the impact they're having on our patients, which will also assist us in the prognosis that we formulate. So let's go back to Emma and look at her risk versus resilience factors. So she did report some anxiety about her productivity. It would be good to know a little bit more about that. She also is requesting the taxi driver to avoid the side of the crash, which is clearly a form of avoidance. And so those are going to be on the risk side of the ledger. On the resilience, protective side, we can look at her specific coping strategies, the rest and heat that she's using, the medication she's taking, the reduced hours at work, the reduced home activities. And we can make judgments when we listen to these things as to whether we think they're adaptive, appropriate for their stage of the presentation, or are they unhelpful? Are they creating barriers? And this gets to the point of how do you judge when a coping strategy is relevant or not? Because if you feel their coping strategy is actually creating a barrier to the recovery, so the rest is excessive, the medication's excessive, the avoidance is excessive, then you can hypothesize that's contributing to the presentation and put it on the list of things to address in management. Okay, so in Emma's case, her thoughts, if we go back through my three categories of thoughts and emotions and coping, she had awareness some motor vehicle crashes were problematic. What's some additional information that would help us analyze that even further? So what I would suggest is exploring further with her understanding of what this means to her. So in particular, the meaning of her symptoms. So even though they might be problematic, does that concern her or not? What are her expectations for recovery? Would she expect this to resolve? What are her expectations for treatment? In particular, her role in the treatment. Does she see herself as participating? And what's her self-efficacy? Under the distress emotions, we know she's anxious about the productivity And it's important when we get an emotion like anxiety to understand the thoughts that are linked to that emotion, because all emotions are tied to some thoughts. And in this case, they appear to be tied to her future productivity. So that's really useful. We also know that she's having these dreams and she's waking with the sound of the screeching brakes. Additional information that might be useful here would be, what's the level of anxiety she's experiencing? What's her response when she's experiencing that anxiety? What are particularly the behaviors? Does she have any specific coping strategies? Or is it such a low level it's not actually influencing her behaviors? And is there any relationship to her symptoms? So when she's in those periods of being more anxious, are the symptoms any worse? The social factors, we have quite a good overview. We know that she's an educated lady. She's likely to therefore have good aptitude to understand health explanations. She probably has a good socioeconomic status with her position as a lawyer, unlikely to be a barrier to strategies that we offer her. Her employer appears to be supportive in allowing reduced hours. Her children and husband appear to be supportive in helping out at home. And the compensation is still pending, so we don't know about that. But they're the social factors that ought to be screened for and listened for in our subjective examinations. Okay, so that was my elaboration of psychosocial focused reasoning and suggestions on a framework to explore a patient's cognitive appraisals, their emotions, their distress, and their coping strategies. The other thing that is challenging about clinical reasoning, when I compare it to just putting on the diagnosis as a broad decision, is the different factors in clinical judgments we need to make. So one area that I've always proposed as an important area of clinical reasoning is, what are the potential sources of the patient's symptoms? Now, sources in terms of her pain in the neck, her headache, her lightheadedness, what are the sources of those? But what we know is clinical physiotherapy examination on its own doesn't have sufficient specificity to confirm the exact structure. And that's why we now hear more and more call for non-specific neck pain, non-specific shoulder pain, or back pain as all we should be considering. I would disagree with that. I don't think we should fall that far back. I think we need to recognize the limitations and the specificity of our examination, but I still think we can hypothesize about joint involvement, muscular involvement, neural involvement, non-musculoskeletal involvement, vascular involvement. So even though there are limitations in the specificity, we can still identify with reasonable confidence the systems that appear to be involved, and hence link that to our management. But it's challenging. Okay, so when I asked this question, we asked this question in our book to the case authors and the clinicians who saw Emma, they answered this by saying, well, it was most likely nociception from the upper cervical segments. And I think most people would make the same judgment. And they base that analysis on the area of her pain, and the referral of pain into the head was appropriate. The difficulty turning her head, which they suggest is likely related to a C1-2 dysfunction. They then talked about the source of the lightheadedness and unsteadiness, and highlighted that it's frequently, but not uniquely, associated with upper cervical problems. And in Emma, it appeared to have a direct relationship. So it's not just that it could be, but it was behaviorally related. So she only felt those when her neck pain and headache were worse. But other possible sources of those symptoms could be vestibular, and it could even be the effect of a concussion, although concussion was considered less likely because she didn't lose any consciousness at the time of the car crash. And even as a symptom of tramadol, because it can be a side effect of tramadol, it needs to be considered. So tramadol being the source of that symptom. But it was also considered less likely because of the temporal relationship, and Emma didn't see that connection. Okay, then thinking about the symptom mechanism or the pain type is another dimension of our clinical reasoning, but also challenging. We don't have absolute biomarkers of pain type, so the best we can use is knowledge of typical clinical patterns that to date are still mostly based on expert opinion. But it's still worth hypothesizing about because of the implications to management and prognosis. Okay, when our case authors were asked this question, they answered that the neck pain was probably nociceptive dominant, but with a likely inflammatory component. And their rationale was there was a sharp pain on movement that occurred on a background of a constant aching pain. And they linked that to the relationship of a specific injury 10 days ago is consistent with nociception, localized symptoms, response, so the aggravating factors to movement, posture, and activity were very mechanical and predictable. That suggests it's nociceptive. And also acknowledge there could be a neuropathic pain type. So most likely nociceptive dominant, but when you consider the high pain, the irritability, the constancy, the difficulty at night, they could also be consistent with a neuropathic pain such as a C2 nerve. When they considered the headache, they also felt the headache was nociceptive dominant, again because of the clear mechanisms of onset, the mechanical pattern, and the headache only came on when the neck pain was worse. But they acknowledge that there could be a CNS sensitization. But this is, I think, quite important because they talked about the sensitization, that is the excitation and sensitization of upper cervical nociceptors is going to be expected after an acute injury. So a level of sensitization in that sense is normal and it's not maladaptive. And that's because the pain being localized and doesn't have the widespread hyperalgesia you'd expect. That'd be something you'd have to monitor so that it doesn't become maladaptive. But yes, it is sensitized, but it's a normal sensitization. Okay, scope of our reasoning. So we're thinking about the activity and participation, we're thinking about the psychosocial factors, we're thinking about pain type, we're thinking about precautions. We need to judge, as you know, whether there's any safety issues related to our physical examination. This is challenging because if you look at those clinical guidelines, they don't tell you this. The clinical guidelines of research doesn't prescribe how much examination to incorporate, how many tests, how many systems to look at, how far to take each movement. So these come from clinical experience and clinical judgment. When they were asked their plan for the physical assessment, they were going to limit their testing. And I'm hoping everybody would think that's what you'd do as well, that you would limit it. The question is, how much would you limit it? And how many things would you look at? And what things would you look at? So they decided they were just going to take their different tests to the onset of neck pain. And the reason is because of, even though you had ruled out the red flag sinister pathology of a fracture, the nature of the onset, the trauma, doesn't rule out she could have something like an instability. So that needs to be respected and the movements performed cautiously. They also highlighted she's got a worsening condition, she's got a degree of constancy, high level of severity, high level of irritability, and this sensitization, even if it's not maladaptive. And all of those things together warrant caution, otherwise the problem is going to be exacerbated at the end of the assessment if too much is done. I would add to what they said also the symptoms that we know can be associated with serious pathology. So the vertebrobascular insufficiency, and in this case, particularly a cervical arterial dissection, is a possible pathology because of the lightheadedness, unsteadiness sensation she's having. So that would further limit our examination. And then you need to weigh up the amount of distress the person exhibits. We're not really sure about the level of her anxiety that she has, but the more concerned you are about fear, anxiety, anger that a patient has, the more you need to pull back on your examination and minimize any risk of aggravation. Clearly, the contraindications are that you'd have not be able to do a high velocity manipulation. You wouldn't do any sort of end range mobilizations either. And there's also excellent guidelines on those safety judgments. I've included here the website from Australian Physiotherapy Association that talks us through those guidelines. Okay, let's look at her physical. Let's look at Emma. And as I'm presenting this, because as I said, there's no research evidence that tells us how much physical to do, I'd like you to be comparing it to what you would look at. What would you have included? What would you have held back on in this first appointment? So they looked at patient's posture, and she sat in a reasonable upright posture. She had relatively normal lumbar pelvic curves, and her head position was in a good position. But she did hold her head rather rigidly, so she wasn't in a relaxed position, and there was evidence of right-sided cervical extensor guarding. She had slight downward rotation of the scapula bilaterally and similarly slight anterior tilt. Active movements, so as I said in the previous slide, they decided to just look to where symptoms were provoked. Flexion was half range with a pulling sensation. Rotation to the right was 10 degrees, acute pain on the right. Left rotation 25 degrees, acute pain on the right. They reassessed the rotation with a facilitated postural position, including spine and scapula, and it had no effect. And extension was 5 to 10 degrees, also painful. They evaluated sensory motor function, and this isn't routine for all physiotherapists, so it's important for those who don't look at this to consider whether this is something that you ought to be incorporating. And they talk through the theory and the actual testing and analysis of this really thoroughly in their textbook. But what they looked at the first appointment was balance, and they looked at the balance in a natural stance and a narrow stance with the feet together. And they looked at it with the eyes open and the eyes closed. And what they found is that Emma was fine in the natural stance position, but when you brought her feet together and eyes closed, after 10 seconds she lost her balance and stepped out. They looked at some other more challenging balance positions, tandem, firm and soft surfaces later on. They weren't evaluated up front. Joint position sense, that's accuracy with a laser on the head of returning to the same point, was delayed because of her limited range of cervical rotation. Cervical movement sense, that's tracing a diagram, again with a laser, was also delayed. And eye movement control was assessed, but just for the ability to follow gaze with the head in neutral. So keeping the head still and following a slow moving finger or pencil at a set distance was no apparent disorder. Gaze fixation, that's where you keep your eyes fixed forward as your head turns. There was no apparent disorder, but that was only able to be evaluated within her limited range of rotation. And then a more advanced test, the smooth pursuit neck torsion test, and that's where you eyes follow with the trunk pre-rotated, was delayed. So would you have looked at that? How much of that would you have looked at? Okay, sensory testing. She was evaluated for sensitivity to pressure and found to be excessively tender to gentle touch, left and right sides of her neck and the cervical thoracic region. It wasn't tested with objectively, it was subjectively assessed with palpation, but they were judged to be increased tenderness. And with this, the assessment was extended to the arms and even into the legs, and there was no generalized tenderness to touch outside the neck region. Sensitivity to cold was evaluated, and this was done using an ice pack applied over the right side of the neck for 10 seconds. And she had a very mild increase in discomfort, up to a 2 out of 10. Neurological was not included, and neurodynamic, examination of neurotissue mobility, mechanosensitivity, wasn't included. Okay, manual examination. Her PPIMs, passive physiological intervertebral movements, were evaluated, And with those, it was found that she had a marked restriction, and specifically she had spasm and pain to rotation bilaterally at C1-2 and less so at C2-3. Passive accessory intervertebral movements were delayed. Neuromuscular control, well, there was no formal cranial cervical flexion test because of her acute presentation, but she was asked to produce the movement. So she was still asked in supine crook line to produce the upper cervical nodding within a pain-free range, and she was able to do about 3/4 of the range of movement before the onset of pain. And then following that trial, her PIVMs were reassessed, and there was a slight improvement in movement and decrease in pain. More extensive neuromuscular control, such as formal neck extensor muscle testing and scapular muscle testing, was delayed. All right, so if you incorporate sensory motor testing, how much of that would you have done and how would you have interpreted her findings? When they were asked to explain their analysis of that, it's that a failure in a narrow stance after 10 seconds for somebody Emma's age, and this even with the eyes closed, would be considered abnormal and would be considered symptomatic of altered cervical sensory motor control. So that's the analysis that's put to it. And then if you look at their work, they highlight that for people under 60 years old, you should be able to stand for 30 seconds in comfortable narrow end tandem stance. And they went on to emphasize that this fits with their hypothesis of an upper cervical segmental dysfunction. And in that segmental dysfunction, not just the joints, but the muscles. And they go on to emphasize that the muscles in the upper cervical region have the highest concentration of muscle spindles per gram of muscle in the body. So that is perhaps the explanation underlying the altered cervical sensory motor control, that guarding and spasm that's in the suboccipital muscles. Okay. What about your overall analysis at this point? Think about your diagnostic and your psychosocial reasoning following the whole examination, subjective and physical. Well, when they were asked to summarize at this point, they came back to the provisional diagnosis of whiplash injury due to rear-end motor vehicle crash. We had that up front. The VAS and Neck Disability Index indicate a moderate to severe pain and disability in classifying that. And then at the impairment level, pain and spasm at C1-2 and C2-3 segments. Painfully restricted movement may explain the cervicogenic headache, so linking those physical impairments to the patient's symptoms. Articular dysfunction and the associated reaction in the suboccipital muscles could explain the cervical vertigo. Psychologically, she appears to have some symptoms associated with post-traumatic stress and some concerns of her ability to function at work, some anxiety. And that touches on sort of diagnostic classification, disability, impairments in the physical domain, and also impairments in the psychosocial domain. Okay, what about prognosis? I've never met a patient who didn't want to know, can you help me and how long is it going to take? And this is another area where we don't have good research evidence to fall back on in terms of prognostic indicators, although there is some useful literature in the area of neck pain and whiplash around prognosis. But asking yourself, what's the likelihood of Emma having recurrent episodes? And I'm going to say that even with the evidence, this is challenging and hard to predict. Okay, well, we know that neck pain is characterized by recurrent episodes, but it's hard, if you look at the literature, to know who is and who isn't going to have recurrent problems. But there's a high risk just in general. So one way to work through this challenging area of clinical reasoning is think in terms of positives and negatives. What are the negative indicators for prognosis in her case? Well, we have the high severity of neck pain that she has, a higher severity of neck pain. We have the higher Neck Disability Index, a 22 out of 50. When she was screened for prognosis or recovery using a whiplash clinical prediction rule, she comes out as having medium risk under that guideline. And then they also emphasize that the immediate post-crash onset of pain and early onset of headache tends to be a slightly worse prognostic indicator. And also, she's got these symptoms suggestive of post-traumatic stress. So the intrusion, that's the dreams that she's having after the accident, waking with the screeching sounds, she's avoiding the car accident. These could be early manifestations of a post-traumatic stress, but they're also quite common, and they will often resolve in many patients. On the positive side, though, and this is what will really help us talk to Emma about her problem, she doesn't have any health comorbidity. She doesn't have a past history of neck pain or headache. The symptoms are very localized. She doesn't really have any strong evidence of cold hyperalgesia. She's continuing to work. She's got good social support at home and at work. She's using mostly adaptive coping strategies. So all of those things weigh on the positive side. Probably a few things that could also be considered here are more information about her beliefs about the problem and her expectations for recovery. That'll help us judge. And whether a person has features of maladaptive sensitization. At this stage, it appears she doesn't, but if those were to develop, they would be more negative. And of course, when there's litigation, that tends to be a negative, and the progression of a patient's problem is important to weigh up. So these are really challenging clinical judgments, and these are the factors you can weigh up to be able to make that judgment and advise your patient. Okay, so management. I'm hoping everyone is also thinking, what would you have been doing? What would you be doing initially, and what are the range of management interventions you would incorporate? So they, lovely, started off with education, and they worked with the GP's diagnosis of soft tissue injury, and they reinforced that by making an analogy to an ankle sprain, which most people are familiar with. So they could draw a connection between the neck pain, the headache, the lightheadedness, the unsteadiness with a sprain of the upper cervical region, and that was explained to Emma. The waking of the hearing screeching breaks needed to be addressed, and that was explained as a common and understandable reaction after a motor vehicle crash, and that it should subside with time. So reassurance was given, as was reassurance that normally there's going to be a reasonable recovery after an accident like this. The benefit of some specific exercises was highlighted. So what physiotherapy had to offer for this kind of problem, including what she would be asked to do in terms of exercises and in terms of managing her loads at work, at home, in order to minimize excessive strain. So that important area of load management was all incorporated in the initial education. Posture and balance was addressed, and that's interesting because there's more and more critique and challenge of whether posture is helpful to attend to. They incorporated posture in the program, and they had her doing sort of a lumbar pelvic roll of their posture, and then they incorporated that with an opening of the chest, and they had her doing this for 10 seconds, this postural correction, every 15 to 30 minutes. But importantly, what they emphasized is they weren't trying to create some long-lasting change in posture, because remember, she only had minor impairments anyway. But what they were trying to do was facilitate movement, reduce joint load, prevent and relieve tension in the muscles, and improve pain. So they were using postural strategies and movements to break up these sustained postures she was in that were problematic. And they were progressed over time to include lengthening of the back. She was also given balance exercises because that was identified as an impairment. So she was then practicing that. So she was in a narrow stance, initially with eyes open for 30 seconds, and then she would rest, and then with eyes closed until she had to step out. And then over the appointments, that was progressed to tandem, and then tandem on a soft surface, always going first eye closed, eyes open, and then eyes closed. Joint position sense was eventually evaluated at the 4th appointment, and that's using a laser, and the accuracy of repositioning was found to be normal. Joint movement sense, and that's tracing, again with a laser on a helmet, the person, in this case, tracing an infinity symbol and looking at the accuracy and the smoothness of it, was found to be impaired. So she had inaccuracies, and that was therefore given to her as a home exercise. She was loaned a laser. Eye movement of control, they then went on and looked at the smooth pursuit neck torsion test, and that's eye follow with the trunk pre-rotated 45 degrees, was normal. Okay, movement and muscle facilitation. So remember in the beginning they found that just the nodding movement itself had some improvement to the PIVM reassessment. So this was then taken further. So she was using the craniocervical flexion extension movements in supine, and she was doing 2 times 5 repetitions through 3/4 of the range twice a day. And she was using those with eye movement to facilitate the upper cervical movement. And then that was progressed to doing it with holds over time. And again, this is not in this, and the authors make a really nice point about this. This wasn't just used to train the deep neck flexors, which sometimes simplistically people only look at it for that value, but they emphasize in their case that they're using it to facilitate pain-free movement, deep flexor control and activity, reciprocal relaxation of the extensors, which remember were guarding in her rigid neck, and upper cervical mobilization, all of which was done pain-free. So it's producing painless afferent input into the CNS. So think about the multiple effects that they can have. Eventually, of course, they then went on and did the formal testing, and that allowed them to objectively measure what she was capable of doing, and they started her off at a formal training program, 22 millimeters, and progressed her initially with the pressure biofeedback and then without the biofeedback. They also had her in 4-point kneeling. And in 4-point kneeling, they were also doing the nodding, but with the gaze fixed between the hands, and they were doing rotation. So rotations within a pain-free range. So targeting the suboccipital rotators and the extensors and movement, particularly of C1-2. So for example, they started that off as a home exercise, 2 times 5 repetitions twice a day in their pain-free range. Okay, and as far as manual therapy, so you can see they really address quite a few different components or systems. Here, the articular system. They used a trial of mobilization with movement for rotation at C1-2, and that had a decrease in pain and an improvement in movement, so that was progressed over the appointments with an increase in range as the pain improved. And then eventually they also added passive accessory assessment and treatment, but that was just used as pain-free passive accessory glides to again introduce pain-free movement into the spine, into the central nervous system, not to stretch or to provoke pain. Okay, reassessment, well, I won't go through all the reassessments because you imagine they reassessed subjectively and all the physical impairment, but this slide just captures the main functional reassessments. So there were a total of 9 treatments over 13 weeks. They reassessed the VAS scores, the neck disability index, the patient-specific functional scores, and you can see there was progressive improvement all the way across until the end, when she had almost normal scores for everything. Okay, and what I really want to emphasize is there was a buildup of home program right from day one. So she was given and asked to take a share of the responsibility, and this is developing self-efficacy, which is so important. So she was doing self-mobilizations for movement. She was doing craniocervical flexion exercises at home, initially in supine, also in all-fours position, and then eventually she was doing them in weight bearing and sitting against a wall. And progressed to even doing them with weight. So they were putting a helmet on her and giving her weight to be able to do the exercises. So the craniocervical was progressed, the all fours was progressed, the all fours was progressed to being done with weight on a helmet. Active extension was introduced in weight bearing when she was able to do it in weight bearing. So initially it was started in all fours, that was more comfortable. Then it was progressed to sitting, and she was taken initially just to P1, then she was taken to holds, then she was taken to doing it under further and further range of movement. The balance exercises were practiced from day one and progressed. The tracing the infinity sign was progressed as a home exercise. And eventually even her thoracic spine was incorporated into a movement exercise, archery exercises to break up the sustained postures that she had through the day. Now, if I go back to my initial title, Diagnosis is Easy, Reasoning is Hard, what I want to really bring this full circles around to is the important but challenging clinical judgments. So we must be thinking and categorizing across a range of important areas, not just the broad diagnosis, whiplash-associated disorder, but our hypotheses about the pain type, our hypotheses about possible sources. Sure, we can't be specific about the tissue, but we can identify the systems, the articular, the muscular, the neural systems, and the levels of spinal involvement. The psychosocial assessment, which I'm really arguing needs to be extended, more structured. So what are the psychological and the social factors? Are they relevant in each patient? What's our management? Screening for contributing factors, especially for those patients who have spontaneous onset, but also contributing factors to the maintenance of problems, thinking physical, psychosocial, environmental factors. Thinking through the precautions of our examination so we get that right, not over-examining, over-treating. Thinking about our management being multimodal, and that a management is going to be tailored to our individual presentation, but following the guidelines, but really targeting the impairments and the function that we identify. But think about the dosage and the progression. And this case is a nice example of how multiple things were done and progressed over time. And then that challenging decision of prognosis. Think of the positives and negatives to come up with your prognosis that you can talk through with the patient. And my last slide is that if we're going to minimize errors in reasoning, the best strategy to do this is to use screening. Don't assume if it's not volunteered, it's not present. That'll lead to a reasoning error. Screen through the body chart, screen through the aggravating factors. So you screen for other potential aggravating factors, other potential predisposing factors. Importantly, qualify the patient's meaning. So you qualify on the body chart all the time. When you say it's your shoulder, show me where. When they say this is what aggravates it, what is it about that? So constantly qualifying. When they give you a psychological factor like anxiety, we need to much more information about that, qualify it to judge its relevance. And then lastly, the more you're able to subject your reasoning to others for their feedback, the more you can minimize errors. And that's really what hopefully this case does. So thank you very much.